When I work with trainees, one of the things I encourage them, whether they're a med student or a fellow, is ask their stories. I usually say, tell me your first experiment with recreational drugs or prescription pain meds. How did this all start? When you just give them space to tell their stories, you realize they're survivors. And a lot of them have had experiences trying to get into recovery and they failed, and they bring that to the table. I tried and this didn't work, and I can't get beyond this. And they have this whole host of failures as part of their story and their identity. I see patients who are housed for the first time, have a paycheck for the first time, have a significant other that is a healthy relationship for the first time.
Yeah.
And all it takes is one of those stories to make you realize this is the work I'm supposed to be doing.
Substance use disorder touches all our lives, and often we feel hopeless or frustrated in our pursuit to understand how and why it happens.
Welcome to APC Recovery Cafe, where we discuss the topics and trends around substance use, provide education and resources, offer recovery support, and also discuss prevention tactics, all through the stories of the people who have been there.
We invite you to grab your favorite coffee or tea and join us for a variety of guests that will bring understanding, information, connection, and hope.
Together, we can break the stigma and pave a brighter future for each other.
Hey guys, welcome into this episode of APC Recovery Cafe. I'm Art Wimberly, a person grateful to be in long-term recovery and one of your co-hosts today, and the other host is Carrie Wimberly.
Hey guys, I'm Carrie Wimberly, Executive Director at the Addiction Prevention Coalition. Glad to be here today. APC is a nonprofit in Birmingham. We focus on awareness, prevention, and connection in relationship to substance use disorder. And we have a very special guest with us here today. It's Dr. Ellen Eaton. And I'll tell you a little bit about Ellen in just a minute. But first of all, welcome.
Thank you. I'm so glad to be here this morning.
We're thrilled to have you. And you guys are figuring out that we basically bribe people with their favorite drink, coffee beverage, to join us. And Ellen, tell us about what you have there.
This is a iced coffee from Caveat Coffee, which is in Homewood.
So it's a black and tan?
Black and tan, yes, thank you.
And what is that?
A black and tan is half draft latte, which is the tan, and half cold brew. So lots of caffeine, little dairy, a little sweet. It is perfect. So I highly recommend the black and tan.
Dr. Eaton, your specialty, if you will, or kind of where your passion is kind of the intersection, would you say, of infectious disease, mental health issues, and addiction. Can you explain a little bit about how that came to be?
I am an infectious diseases physician, so I went through my training as an internal medicine resident and then knew I wanted to get specialty training in infectious diseases. I really liked working with patients with HIV. That was really what drove me into infectious diseases. And like HIV, a lot of our patients with infections have multiple social determinants of health, a lot of poverty. I mean, you think about TB, you think about hepatitis C. Our patients are involved in criminal legal settings. They are homeless. Many of them have worse outcomes because they don't have access to antibiotics and doctors like insured members of our community. So I was really drawn to that population, and throughout my training saw a lot of mental health, a lot of addiction, but it wasn't until about 2017 that I really got involved in clinical research around substance use and got my X waiver to prescribe buprenorphine, which is a treatment for opioid use disorder. That was really fortuitous. I got a really cool fellowship through the National Academy of Medicine that was a public health and policy fellowship for 2 years, where I was going to the National Academy of Medicine in DC every couple of months. Wow. And working with study sections, working groups, and the hot item then, which is still a hot item, is the opioid epidemic and infectious diseases. And because I was an ID doc, I asked to be put on that working group, got to work alongside national leaders who work with patients who have opioid use disorder and HIV. And just through working with them and getting mentored from these national leaders, I realized, hey, nobody's doing this at UAB. Like, nobody has really championed this nexus that you mentioned of infectious diseases and addiction. Came back to UAB, started looking at our patients, our hospital outcomes for our patients who inject drugs, which is a significant number, over 100 a year, come to UAB with injection-related infection. And because really there was no one working in that space, either doing research or patient care, it was really ripe for me to get involved both as a clinician, as a researcher. And I'll say since then, I've really had just tremendous success that I'm incredibly grateful for. Every grant that we've really put in this space, including what I'm working with APC, has been funded, I think, because our funders, whether it's the NIH or SAMHSA, the Substance Abuse and Mental Health Services Administration, or these foundations and nonprofits, they appreciate that when we put in a grant and we spell out the problems, the overdose crisis, the HIV epidemic, we've just been really grateful for the funding to do more work in this space. There's a tremendous amount of work to do. We're constantly trying to grow our team, right?
Yep,
Recruiting other clinicians, other researchers, which, has been challenging in the last couple of years, but we're not giving up.
Yeah.
So, okay, so take us back. Where are you from originally?
I'm from Dothan, Alabama, Southeast Alabama.
Always knew you wanted to be a doctor? Where did that calling come from?
Yeah, great question. I wanted to be a doctor. I wanted to be a pediatrician. My dad's a cardiologist. I grew up in a medical family, loved my pediatrician, shadowed pediatricians when I was in high school. But when I came to UAB for medical school, I realized a lot of pediatrics is well baby visits, and it just wasn't as exciting for me. Whereas when I did internal medicine rotations working with adults, there were a lot more exotic diagnostic dilemmas, if you will, sort of like house MD. A lot of the really interesting pathology, especially in infectious diseases, was really engaging for me, whether it's syphilis or some tropical fever, malaria. We see it all, which when you're 23 is really excited. When you're my age, you're kind of like, oh, this is a little bit much now to work up these really challenging diagnostic dilemmas. But that's what really got me hooked in infectious diseases, just the breadth of pathology. Wow. Never you could walk in Monday and see tularemia, something that, maybe even your attending has never seen outside of a textbook. So that's what drew me to infectious diseases.
Interesting. And then you traveled.
Yeah, so I did my med school at UAB.
Okay.
I did internal medicine residency next at Stanford. Okay. Had a great experience there. Loved California, learned a lot. Was fortunate enough to stay on for a chief medicine year there, where I got to be a clinician, educator, instructor, and train other residents. And then I moved to North Carolina for a 2-year chapter where my husband did his graduate degree, and I was a hospitalist at Duke Hospital. But always knew I wanted to come back to do infectious diseases at UAB, and that's what I did in 2012.
Okay. And then
I've been here.
And then he moved here with you.
Yes, that's right.
Y'all were married?
We married actually in California.
Oh, cool. Okay.
So we kind of bounced around.
Let me see if I've got this right. This shabby educational background here, UAB, one of the premier schools in the country, and then Stanford. Mm-hmm. Didn't you visit Vanderbilt for a little while?
That was my undergrad. Yeah, okay. So that's where I went straight from Dothan. Yeah. Sorry, I skipped over that.
And then at Duke.
Yep, Duke.
Okay, so we could probably trust her on some of this stuff, right? Yeah.
One thing that you talked about that you wanted us to discuss is the stigma. And I think, getting back to that challenge of recruiting other physicians and researchers to help me do this work in the Deep South, it's been hard. And even physicians and researchers who study very vulnerable groups, patients with HIV, patients who are in and out of criminal legal settings, living with housing insecurity, it's still really hard to get people interested in substance use. And I think it's that there is a certain amount of stigma, even amongst providers, even amongst researchers. It's implicit. It's not intentional. Yeah. They don't wake up and say, I am not writing a grant with those drug users. Like, no one thinks that overtly, but I think it's just this implicit bias, this stigma. And when I work with trainees, one of the things I encourage them, whether they're a med student or a fellow, is ask their stories. And when you ask people their stories, and I usually say, tell me your first experiment, your first experience with recreational drugs or prescription pain meds. How did this all start? When you just give them space to tell their stories, you realize they're survivors. And I'm not supposed to have favorites, but y'all, my patients who are adult survivors of like the foster care system, those are my favorites. And they come to me and they tell me things like, I don't remember anything until I was 10.
Oh, my
And that
goodness.
just means there's so much trauma. My interpretation.
Yeah.
Shut
Again,
down. They had to shut down
They shut
early.
down. I'm an infectious diseases doctor. I want to make sure people know that I'm board certified in ID, and I do prescribe buprenorphine for opioid use disorder, but I am not a psychiatrist. But to me, that tells me there was so much trauma, neglect, abuse, et cetera, that these kids, and it's often little boys, were in and out of aunts and grandmas, and finally, were taken out of the home, placed in another setting that often wasn't. Now, there are wonderful foster parents, and I do not want to come off as saying that we don't have wonderful, amazing foster parents.
Yeah.
But a lot of my patients did not have wonderful, amazing foster parents. And I tell them, before I talk, after they share their story, I tell them, you're a survivor. Like, let's stop right now. I don't want you to think I'm coming here as this diseased person who has this moral failing that, is just grateful to have a doctor to listen to them. Like I say, full stop, you're a survivor.
Yeah.
And you've made it to age 24, and that is amazing.
Yeah.
Yeah, you're helping them recreate their story.
Absolutely. And a lot of them have had experiences trying to get into recovery, and they failed, and they bring that to the table. I tried, and this didn't work, and I can't get beyond this. And they have this whole host of failures as part of their story and their identity. And so I think it's really empowering for me to say, you're a survivor. This is so inspiring. You're the kind of patient that I come to clinic for, because I know that it's going to take time, and it may take you 10 attempts, but like you have the potential to do so well.
Yeah.
And especially with our amazing treatments that we have for opioid use disorder.
Yes.
I see patients who are housed for the first time, have a paycheck for the first time, have a significant other that is a healthy relationship for the first time.
Yeah.
And all it takes is one of those stories to make you realize, this is the work I'm supposed to be doing, and I can carry on. Now, don't get me wrong. There are clinics where everybody is having a really hard time, and they're all, about to lose their housing. Their mom just died. They're slipping back into use and out of recovery. And those are the days when I, go home and feel exhausted. But every now and then I'll have a clinic where there's so many success stories, or sometimes there's just one, and it makes you realize we can do so much good just by being present, helping people rewrite their stories, and giving them space to tell them their stories, and reminding them that they're a survivor.
Yeah.
And a lot of it, I think stigma.
Yes.
In healthcare settings, unfortunately, contributes to that narrative that they come to us with.
I was wondering, do you think that your variety of education in different geographic spots of the country has impacted the way you see this?
Absolutely. And I tell my colleagues, and I tell my trainees all the time, because we have a lot of wonderful colleagues who are what we call UAB lifers, quote unquote lifers. Yeah. They did undergrad, they did the early into med school acceptance, residency, et cetera, which is wonderful. UAB is wonderful. Again, I'm not trying to disparage UAB, but having seen how medicine is practiced and seeing vulnerable groups in California, we had a lot of refugees. Our migrant population was totally different. The politics and policies were different, much more progressive in terms of harm reduction.
For those that may not have a loved one, struggling with substance use, and you hear us talking about stigma a lot and trying to break that down. The reality of only really much less than 1 in 10 gets the help that they need if they have a substance use disorder before some sort of crash. So every time we're out in the community educating, we're like, what if, we got that up to 2 out of 10, 3 out of 10, 4 out of 10, what a difference that would make, so that you normalize this struggle, and we educate people that it's okay to go and talk to your doctor or a friend or a counselor and say, you know what, I think I'm beginning to form a dependence on this medication I'm using, or on the alcohol, the glass of wine that I have at dinner, or on marijuana use, that dependency, emotional and physical, and being able to talk about that, So that's what we're talking about with stigma, because addiction really is cultivated and grows in isolation.
Absolutely.
Bringing it out into the light is where help and recovery is possible. So that's the reason we spend so much time and energy talking about that.
Yep. Absolutely. And what I remind my colleagues and certainly our trainees is that for our patients who have diabetes, if they quit using their insulin or don't use it correctly, or they just got tired of sticking their fingers and checking we do not dismiss them from our clinic. We do not shame them. We don't label them as a bad patient, right? But too often our patients who are struggling in and out of recovery, on and off treatment, we label them. We make them feel unwelcome. Some clinicians fire them from their clinic. That would be considered malpractice for a diabetic patient.
Yes.
But for some reason, culturally, we've made it okay to penalize patients who are struggling with this chronic disease of addiction.
Yep. Is it a fair question or a good question to ask where the intersection of the research and how's that coming together? What are you seeing as maybe new information or changes or?
Yeah, it's a great question. Virtually all of my research is clinical research, which means it's not in a basic science lab. My lab is my clinic, and my specimens are really the electronic medical record where I can track patients. Did they come to clinic? Are they taking their medications? Is their HIV under control? Those types of outcomes. I can give you a recent example that we published was my at the 1917 HIV clinic at UAB. I have an opioid treatment clinic where I treat patients with opioid use disorder and HIV, and many of them also have alcohol use disorder, stimulant use disorder, a lot of these things, and mental illness. These things go hand in hand. But one of the research questions that we had during the last 2 years, the pandemic, was how are our patients doing? We started our clinic in 2019, like 6 months before COVID. And then we had to rapidly pivot patients from in-clinic visits to telephone visits, audio-visual telemed appointments. And so we did an analysis of really 2019 to 2021, looking at how did attendance look? Was it in person? Was it over the telephone or over a smartphone? How did recovery rates look? How did HIV control look? And so we did an analysis to show that our clinic, although it's small and new, was able to really keep people engaged in care by having these options. It's really exciting to me because we've had a lot of great policy relaxation. So I can now start people on buprenorphine the day they leave jail over the phone. Wow. That's a COVID provision. It used to be illegal. They used to have to come physically to me. But if my patient lives in Talladega or Walker County and they're very high risk for overdose because they're newly released after being incarcerated, it's a lot safer if I can get a phone call, do their encounter over the phone, call in their buprenorphine, call in their Narcan, and see them at my next available appointment. So we did an analysis. We wrote a paper and we titled it "Safer in Care." Because there was this safer at home language, but this is safer in care. And I called it a pandemic tested model of care. And the whole premise is that the clinic is no longer just the brick and mortar. There's a lot we can do virtually. And we're hoping that a lot of these provisions that allowed us to do virtual care will remain, because we've realized that a lot of our hard to reach groups do better with a phone call. And frankly, a lot of my patients who are doing really well do better with the phone calls because they've got kids. They got to get their kid to school. They got to get to work. They want to keep their jobs.
Not very easy for them to physically be in the place.
Correct. And a lot of them live, opioid use disorder affects a lot of rural communities. So a lot of my patients are coming from like Jasper, Talladega, Tuscaloosa, all over. I have a patient that comes from Georgia.
Wow.
Which is a whole nother issue because that's crossing state lines and there's additional policy around not being able to, so he's limited in what he can get. But hopefully these provisions will be more friendly in coming years to that virtual clinic and extending care to accommodate.
Yeah. I want to go back to something, Carrie, you said we need to get back to about harm reduction, because that kind of, I think, would come under the bigger heading of, in a sense, medically assisted treatment, which is still, in fact, we talk about a stigma around recovery and addiction, but there's a stigma around medically assisted treatment and the role it can play. So maybe you guys can talk about that a little bit.
Yeah, in our, we do a Parents of Addicted Loved Ones group, on Thursday nights. And MAT is a topic that we try to touch on and educate on, because unfortunately, I'm not going to say a lot, but some of those parents have an understanding about, or lack of understanding about why that's so important. And, so we try to have really honest conversations, to the best of our ability about, okay, why MAT? Why MAT around opioid use disorder? Why that might look different. Also around, can it be abused? Yes, it can be abused like many other substances. Also, you're just trading one drug for another, and then also, an honest conversation about it needs to be more than just that. It needs to be counseling and recovery and sponsors and process. So anything you can share with us about that?
Yeah. Unfortunately, I have a handful of patients who want to get off of their buprenorphine because my family calls me a junkie because I've traded one drug for another, or I can't go live with my aunt unless I'm off this, or unfortunately a lot of recovery places require.
Allow it. Yeah.
And I've had patients that spirals into a relapse where they self-taper or they just stop cold turkey because
it happened to our
It
son.
happened to one of our sons who was
year.
successful on methadone maintenance because of his heroin. He was so afraid he was going back to it after he saw his friend die of an overdose, and went straight and got on methadone and was functioning well, and then decided to come off and didn't get medical assistance. And boy, that was a crash.
I'm so sorry. That's really hard. Yeah. It's hard to watch. I don't recommend it. There's great data that patients that are able to stay on their opioid agonist therapy for 6 months or longer are much more likely to stay in recovery and be stabilized.
Yep.
What I've noticed is that even my patients, like I'll give you one success story who's in her late 40s, early 50s, has been in recovery now for 3 years, is back in school getting a social work degree, works part-time, and has her own apartment. She's a tremendous success story. Even she says, I'd like to come down to the lowest dose I need, but I just feel like this is stabilizing me.
Yes.
And if she, if she really wanted to get off, I'd work with her on that. We'd try to slowly, down titrate her meds. But just like going back to the diabetes example, a diabetic may need insulin. She needs buprenorphine. It's allowing her to be healthy. She's contributing to society. She has, she's happier now than she's ever been. She told me my life began when I got treatment.
Yep.
My life began when, actually, she says her life began when she was diagnosed with HIV, because that's what was the trigger for her to get treatment for both her substance use and her HIV. So she says, Everybody says HIV is a death sentence. Actually, my life began because she's had, 20, 30 years of substance use, homelessness, et cetera. So she's the type of person who's stabilized all the people, places, things, all the trauma. She's worked through it. I might consider allowing her, if she wanted, to give a trial off her buprenorphine.
Yep.
You could make the same case for somebody on methadone. But in general, I do not recommend it because the data is just so clear that these patients, just like a diabetic, needs supplemental insulin, just like someone with depression may need a supplemental antidepressant, or a child who has low thyroid hormone may need supplemental thyroid. We should be normalizing these medications, and we should be, I think it's a life-saving medication. I tell my patients
if it
that.
got more normalized, do you think that we would invest more time and research into making more effective ones, if there is such a thing?
Yeah, it's a great question, like the whole pharmacotherapy and where the field is going. I will say that right now, the biggest challenges I see for my patients are not that the drug doesn't work, it's that the systems don't work. And we even have like a long-term buprenorphine now, a long-acting injectable. But y'all, the challenges are a lot of insurances don't cover it. It requires all these complicated storage, refrigeration, infusion. It's really hard for a small clinic, to be able to afford the infrastructure to administer that. There's all these hurdles with insurance and prior authorizations, et cetera. So that's an example of a great, innovative, new long-acting, once-a-month injection that I haven't been able to get to my patients because it's all these systems that are broken.
Yep.
Is that?
Yeah.
Great point. No, it's a great point. Carrie, I don't know if you want to do kind of a promo for Thursday, because it just so happens that the guest speaker at the family meeting is going to tell her recovery story, but then talk about, from a professional standpoint, medically assisted treatment. So I don't know if you want to just give a blurb about.
Yeah, we're having Kim Lamar is coming to speak at our. We bring people into the parent group, try to about monthly that have a recovery story, because as parents, it's so encouraging to see people that have been really struggling with substance use disorder, and even though it's been sometimes years and decades, they find their way out to health. But she's a peer support specialist and works with MAT at Pathways, and has an amazing story of gaining sobriety, but not recovery.
And having to come back and deal with a mental health issue while she's sober to keep her from going back. Yeah.
Yep. It's very, very, very interesting. Okay, so talk just a minute about Project LEAP.
Yeah.
And the goal of that. And then let's come around to the community aspect of that, what the grant itself is really looking for, which also includes harm reduction. And we'll talk a little bit about fentanyl test strips and maybe syringe services that we don't have yet.
Yeah. So LEAP is the grant I mentioned earlier. It's around linkage, education, and addiction and HIV prevention and treatment if we identify young people who are already living with substance use or HIV or other complications. This is the grant that SAMHSA called for applications in 2019 around prevention navigation, having someone who could navigate patients who are at risk through education, prevention awareness, linkage to services. And we successfully submitted that in 2019, and it was funded in September 2020. And once we developed our team, and Carrie being a primary part of that grant, we then identified other stakeholders in the community that may have touch points with young people at risk for addiction and HIV. We know that Birmingham City Schools, we definitely have an HIV problem. We are a hot spot, and most of our new infections are in young people, teens, 20s, young 20s. So we started reaching out to people like Suzanne Muir, like UAB Beacon, Addiction Recovery at UAB. I reached out to the Recovery Resource Center, Jefferson County Department of Public Health, and even our AIDS service programs like AIDS Alabama, Birmingham AIDS Outreach, and more recently, Magic City Acceptance Academy. Just to see, if people are interested in allowing us to come into their programs, do some education with their staff, making sure their staff realizes that the population they're serving is at risk for not just addiction, but also HIV and vice versa. We are recruiting participants, young people who are ages 13 to 24 at risk for either addiction and or HIV, which if you're living in our community and you're within those ages, you basically qualify. And for those youth that qualify, if they are interested in participating, they complete some screening questions that are standardized questions to understand their risk for addiction, infectious diseases like HIV, like hepatitis C. And then based on those results, our peer navigator, Ashley Loftus, who's lovely, has a counseling background. She's wonderful with young people. Will refer people to services. So these young people, if they're at risk for HIV, if they're showing signs based on their reported substance use of addiction or substance use disorder, she'll help make connections for them, whether it's the health department, whether it's an HIV test. And then she's also training young people to be a part of our team by training them on what to look for amongst their peers. She's gotten them training to do HIV testing, which is a great skill for them to have, put on their CV, and also contribute to additional community outreach. And what I think I've been most proud of are the really innovative pop-ups that Ashley's really led that allow us to work with the health department, other community organizations, nonprofits, to meet downtown and have a pop-up fair, a resource fair, to offer Narcan. And then we'll be adding, hopefully soon, fentanyl test strips, which have just been legalized in Alabama, with the goal that people who are using substances, even one time, even experimenting with substances, can know if the product they're using is tainted with fentanyl. And what we're seeing clinically, and I know we're seeing it in the news, is that a lot of young people are just experimenting one time, and they think they're getting a pill that someone says is a benzo. It's going to help you relax before your test, or it's going to help you relax for this social anxiety, so you can go out to this party and drink beer with your friends. And that one illicit pill has fentanyl, and that child never wakes up. And so the goal is that by having an awareness, by having this test strips that people can test their supply, hopefully will help us identify fentanyl. It's still very early in the implementation. I think we have purchased those with some of our grant funds, and we're going to get them to our pop-up fair. Yay! So it'll be real interesting. And I'm also really interested in collecting data, like you and I have talked about, Carrie, just to see, are people using them? What is their experience? Did the product they have test positive for fentanyl? Did that make them not use it? We're assuming that people will say, oh, I don't, I'm not going to use this, but we don't, this is a totally new product in our community. And we're hoping that this is not the end of harm reduction. We're hoping this is just the next step. It's another way to broaden the conversation discussion around harm reduction. And to your point, I think we'd all love to see more syringe service programs and other harm reduction. These are evidence-based services. They were used in the Indiana HIV outbreak in 2012 to stop the HIV outbreak in patients who inject drugs. We know that they reduce hepatitis C, they reduce a range of infections, but more importantly, they allow us to normalize substance use. And for those community helpers and partners who are helping to provide these, it's an opportunity to talk to these neighbors and residents. It sounds like you're really struggling. Have you considered going to treatment? I know that you're still injecting, and I can't keep you from that, but could we talk about getting you into mental health services? Can we talk about, these other services that we have, whether it's social, whether it's, do you need a meal? Do you have a wound? Can I help you with your wound? So when I've gone to other places that have more evidence-based harm reduction, they use it as a wraparound, one-stop shop for, food, nutrition, crisis mental health services.
So you're saying regardless of whether they take advantage of a particular harm reduction or medically assisted treatment or test strip, it's increasing the touch points with the population that they might get different help or more help, right?
And we do this for less stigmatized crises, right? Like a rape crisis center. They don't just, respond to the rape. They're also going to check for STDs and pregnancies, and they're going to provide counseling services, and they're going to provide emergency housing if you're leaving an intimate partner violence setting. So that is, we as a society, we've decided that person is a victim worth helping. And as a society, I'm not sure.
I love that.
I'm not sure as a society we've decided that patients who inject drugs are a victim worth helping. And I think this is how you help that. You have podcasts like this. You talk about patients like this. My example of the survivors. So we're chipping away at, we're peeling back the layers of the onions. We've got fentanyl test strips now, and hopefully we'll peel back more layers as we work together.
And so that people are not so afraid. It's like they're afraid of this space, and it's through education that you realize this is a good thing. One thing about this project that I think we're both really proud of, and I see it in action is. We have an advisory board that Ellen mentioned, and there's so many of our partners that are part of that call. That is it quarterly? Quarterly call, that's one of my favorite meetings. Like I had to miss one like 2 quarters ago, and I was like, oh my gosh, because every person has their particular space that they're working in, whether it be the recovery community in Birmingham or, AIDS Alabama or other things. But when we come together and start talking about the next resource fair or the next opportunity, you see all of these people working together, lighting up in their space and thinking of ideas. And I just don't think I've ever, we end up being so siloed and working over here and working over here. We don't know what each other are doing. But man, when you come together for a common, passion, and each people, bring their groups and their resources, I mean, it's powerful, you know,
It is very powerful.
and
It's
that-
also my favorite group
Yeah.
too.
yeah. So
great group.
we're, you know,
And that, I think, has been a goal for APC for a while, is the collaboration,
yes.
trying to improve on collaboration.
Yeah, because I mean, as a whole, the substance use disorder, resources, recovery, I mean, in Birmingham, we've just been so disconnected. And there, you know, we can't be successful disconnected. So, okay, so back to you personally.
Mm-hmm.
You have 2 really cute little boys.
Thank you. I think so.
What are their ages?
So Hatcher is 9 and Hall just turned 7.
Oh my gosh, they're so cute. I have to show you a picture. He's not on social media. So what do you guys do to have fun
Wow.
when you're not working?
When I'm not working. Right now it's summertime. It's pool season. Like, we love being outdoors, in the sun, in the pool. I think the pool is fun because it's just so hot in Alabama. You know, this time of year, they're real bookish. They're both bookworms. And I say that just that they are not super sports kids at this point. So
yeah.
I think a lot of people with boys this age are on the ball field
Yeah.
but my kids, summertime is the library, it's reading, and it's swimming pool. And my husband and I both enjoy reading and swim pool. So that's kind of our summer thing on the weekends.
Are you a runner?
I'm a runner.
Okay, I
Yeah.
thought
And I would
that.
love it if they at some point develop an interest in running. So I love running as one of my summer things. And I love the longer days and the sun being up earlier when I'm running with my
So
friends.
if you could run in the swimming pool with a book,
That would be great. That would be great. Yeah. Yeah. I love, you know, this time of year, everything's green. We have so many great trails
Yeah.
in and around Birmingham. One of my favorite things. Yeah, and just being with the kiddos. The oldest one's at camp right now. The younger one just got back from a week at grandma camp. So we're just down to 1.
how do you stay optimistic based on what you do? Because you're not just in the clinical research in the tower, you're on the ground, right? At these levels, how do you stay optimistic about what you do?
About staying optimistic about what I do. I think it's really just leaning into this notion that it's kind of peeling back the onion. Success is going to look different for every patient. And sometimes success for a visit is that the patient showed up. They showed up to clinic, and that is success. Sometimes it's that they started treatment. They're actually physically in clinic. I can check their laboratories and make sure everything's looking okay, and we can give them a food box on the way out. And to some docs, that would be frustrating because they are seeing a clinic full of patients and nobody's in recovery. But I think just redefining what is success. What is success for this patient population? And again, they're survivors. So every day that we can keep them alive, we can send them home with Narcan, which we do for everyone and their caregivers, reaching them where they are, not where we want them to be.
Yes. Thank you for trusting APC enough to partner with us. It's a privilege. And I've just enjoyed getting to know you and developing a friendship with you. And I look forward to big days ahead. So,
Me too. Thank you so much.
all right.
Well, folks, thanks for joining us for this version of APC Recovery Cafe, and we'll see you next time.
One of the things that APC is known for is being a connector because we're stronger together.
Not only are we there for those who are suffering through substance use disorder, but we're there for family members, and we really take our job seriously.
We all have personal reason why we're in this field. We're changing people's lives one community at a time.